All right. Okay. All of our little details taken care of here. Well, thank you, Laura, for a wonderful explanation of the reimbursement implications for the home nutrition support patient. And Alison and I will now be discussing the processes and clinical considerations for the home nutrition support patients as we transition from the hospital into the home setting. And got a little bit of a cold, so bear with me. Hopefully the voice will last. Now, we have several objectives today, or actually just 4 objectives. We're going to review how the implications or the implementation of Aspen guidelines helps to ensure a safe transition of our home nutrition support patients, and describe the benefits of having that multidisciplinary team approach, as well as using a standardized order set for enteral and parenteral discharge orders to secure a safe discharge. We're going to identify the goals of care, any metabolic concerns, and any other barriers in an effort to optimize the discharge on home nutrition support. And then with all the information that we convey to you today, we're going to apply that in a few case studies. I have no disclosures. And I'm going to start off by describing or talking about first the transition of care for the PN patient from the sender's perspective. Because I'm in the hospital, let's say, I've been in home care as well, but right now I'm in the hospital. I'm going to convey on some of those important points. Now, excuse me, in an article that came out in NCP in 2022, the consensus statement for safe care transitions for the patients on PN, they listed 6 key steps that were important in the transition process of the PN patient. And as we see here, those 6 steps, I'm going to look at each of those individually. And the key thing to remember is that we want to provide a safe and sustained discharge. In other words, we don't want patients coming back into the hospital. Now, as we go through these steps, you may want to think about how this is happening in your facility. And if you're having any obstacles, as many of us do, you may want to consider setting up a task force in your institution to help optimize this whole transition process. So as we know, one of the first things we need to do is identify the patient early on. We've all been told about this for years and years. Discharge planning begins on admission. We need to review the indications for PN. Do they meet Aspen criteria? Is the PN needed for short term, for long term? We need to review the PN order set to make sure that that's appropriate for transfer. Are the substrates at goal? Has the patient been cycled? Are the electrolytes in relatively stable mode? We also need to convey to the patient and caregiver education and training from in the hospital setting before they get out into the home setting as well. And optimally, they should at least have some type of introduction to the PN therapy while they're in the hospital, and then more intensive education once they get into the home care setting, which will go on for 2 to 3 days. So we need to conduct an assessment on that patient to prepare them for discharge. We need to review the patient's clinical status and make sure that they're feasible for transfer. And then this evaluation should be done by clinicians in both the sending and receiving organizations. It's really important to both have a really good handle on it. We need to confirm that the organization that they're going to be transferring to, in other words, the home infusion company, has the expertise in PN management and to safely take care of these patients. And do they have certified clinicians? Are they certified in nutrition support? That would be great if they are, or at least do they have that type of experience? And then certainly we need to think about identifying and mitigating any barriers to a successful transition. In other words, for instance, do you have a competent caregiver in the home setting? Are they willing to do all the things that are involved in this endeavor of taking care of a home PN patient? And next we need to establish the receiving organization, or in other words, the home infusion company. We need to collaborate with the care coordinators and helping them determine the appropriate organizations that have the clinical expertise to do this. We need to review the patient care needs and support systems and any reimbursement issues. As Laura mentioned, there are many, and also conveying important details to not only the care team in the hospital, but also to the patient and the caregiver. Because oftentimes they'll get home and they don't realize everything that is involved in taking care of these patients. It is very important to make sure that the patient and the caregiver are aware of the cost, the time commitment, and the responsibilities involved in caring for these patients in the home setting. So who will be the accountable providers? Who will manage the patient in the home care setting? We want to make sure that those nutrition support clinicians who will be responsible for managing these patients in the home setting have the appropriate credentials and experience. And certainly we want to make sure that there's appropriate or appropriate contact information for both the sending and receiving organizations. And that information should be transferred back and forth between the continuum of care. So next we need to communicate the plan of care, finally getting to that plan of care. We need to establish the PN goals, both short-term and long-term, define this PN order specifics. And what I mean by that is looking at the macronutrients, the electrolytes, the additives. Are there any additional IV medications that are needed? We need to make sure that we have the appropriate orders for the IV access, maintenance, and care. We need to identify any additional orders that are needed, if we need supplemental IV fluids, any additional IV medications, and certainly have the orders for the IV access, care, and maintenance. Another very important detail is verifying the TPN delivery. We want to make sure that we get the orders from the hospital to the home care provider in a very appropriate time period, preferably before noon, if at all possible, because the more we delay that process, the longer it takes before that parental nutrition can get to the patient in the home setting. And the last thing you want to have happen is a patient gets the parental nutrition at 9 o'clock at night when there may be no nursing available at that time, or if there is nursing available, then the nurse is tired, the patient is tired, the caregiver is tired, and it's going to be a terrible educational opportunity, okay? And sometimes the patients may not even get the PN until the next day. So these are key things to keep in mind. And let's move on to the actual implementation of the plan of care. We need to review all the details of venous access device care and management, and determine if the PN can be cycled before the discharge or if the patient must remain, remain connected to the PN. And for the majority of the patients, they can be weaned off the TPN or CPN prior to discharge and then restarted on the PN once they get into the home environment. They're off for a few hours. It should not be that much of a problem unless, of course, they have insulin in the TPN. That could be a bit tricky. In addition, you should think about transitioning that patient to an 18-hour cycle, if possible. An 18-hour cycle for most of your patients will probably be relatively safe. We need to also think about incorporating any patient limitations into the care plan. And what I mean here is, let's say the patient has to get to a doctor's appointment or may have to go to chemotherapy on a routine basis, so they need to be off the PN by a certain time in order to get out of the house and get the oncology infusion center at an appropriate time. And certainly if patients who must travel and take flights, they need to have appropriate documentation to permit travel with the PN, the supplies, and the equipment. And certainly the patient outcomes should have an ongoing assessment taking place. Now let's look at the considerations, the clinical considerations for the transition of care for the PN patient and from the sender's perspective. We have several here, and I'm going to go through individually. We need to confirm the central access, looking at the type of catheter or catheters, whether it's a PICC, a tunnel catheter, or port, determine the tip location. That's extremely important. We want to make sure that that line is in the true central location, whether it's the distal SVC, cable atrial junction, and identify the number of lumens, and determine the purpose of the central catheter or catheters. Frequent thing that we see is that a patient will be on chemotherapy, will have a port that is dedicated just for the chemotherapy, and they have to have an additional central access device for IV nutrition. So you could have a port for the chemo and a PIC for PN. And we need to identify on the discharge order what central venous access device is being used for the PN. So, our additional considerations, we need to identify the PN goals. What are the goals of care? 4 different goals: anabolic, maintenance, supplemental, or palliative. Now, as you heard Laura talk about, supplemental may be a challenge. We might have some reimbursement issues there. Okay, and this I've included just as a reminder for the Aspen guidelines for PN dosing. The key takeaway points here are to remember that the macronutrients and electrolytes and any additives should be listed in amounts per day, and that the lights should be listed as salt. Now remember, all these are guidelines. Now, per clinical judgment, if you feel that you need to alter these somewhat, that's okay, as long as you're using sound clinical judgment and you're documenting why you're practicing outside of these guidelines. Some additional considerations, moving on to our fluid provision. We need to consider our fluid needs for the PN patient in the home or as they transition to home. These can be adjusted, dictated by the clinical status. If the patient has high GI output or high GI losses, we may need to provide additional fluids. Now, how are we going to provide those? Are they going to be as additional IV fluids, or are they going to be as fluid added to the PN solution? Supplemental IV fluids can be a challenge, again, in terms of reimbursement. They can be more costly to the patient. You may want to consider adding that additional fluid to the PN regimen once they go out. Also, when in the hospital setting, many of the hospitals use a 2-in-1 PN solution plus separate lipid. When they go into the home setting, they're oftentimes going to be transferred over to a 3-in-1 or total nutrient admixture solution. And we need to keep in mind that when that is done, we need to have the macronutrients at final concentrations that are optimal for stability. And next we have our macronutrient requirements. Excuse me. In terms of, and these are all listed out very succinctly here, you may need to go outside of this. Let's say if you have a patient who's got tremendous wound healing needs, you may need to provide additional protein. Important things to keep in mind in terms of the dextrose content of your solution, not to exceed a glucose infusion rate or GIR of 4 to 5 milligrams per kilogram per minute, or a maximum of 7 if you're considering a cyclic PN regimen. For lipid, this is the general guidelines. However, if you have a patient who is a diabetic and you're really trying to minimize the need, if at all, for insulin, you may not want to ramp up that dextrose very high. You may want to use a little bit more lipid to balance out that regimen so you don't have to use insulin in your regimen. Electrolyte considerations, certainly, look at the Aspen guidelines. Consider your acute care requirements versus your home care requirements. Many times your patients have been coming from the critical care setting and now they're coming out to the floor. They may have had tremendous surgery, but as their stress level and their extreme clinical status begins to attenuate, then we can start to see more stable levels of electrolyte usage, unless, of course, you have a patient with high GI losses. Then we tend to need a lot more potassium, magnesium, etc. We need to complete any necessary adjustments or electrolyte replacement prior to discharge. And I'm not talking the day of discharge. That's setting the patient up for metabolic problems going out. You have to keep in mind that these patients are not going to have their labs checked routinely as they have in the hospital. They are not going to be checked, you know, daily or 3 or 4 times a week. They're going to be checked weekly. So keep that in mind as you start making these changes. Avoid aggressive electrolyte changes on the day of discharge, and that not only includes electrolyte, but also fluid and your macronutrient changes and your cycle time. Keep in mind that your potassium requirement should be, your potassium infusion should be less than or equal to 10 milliequivalents per hour in a non-monitored setting. Now, when we're looking at the infusion schedule, we need to consider whether we're going to go with continuous or with cyclic. If your transition is cyclic, remember you need to monitor the fluid tolerance, because even though you're getting the same amount of fluid per day and the same amount of macronutrients per day, you're compressing that time. So you're getting much more fluid per unit time than you were previously. Can the patient handle that much fluid per unit time? If you have a patient who's got edema or ascites, they may not be able to handle that kind of volume. If you have a patient with cardiac issues, they may not be able to handle that type of volume. Avoid a 12-hour cyclic in a PN patient who is NPO. That is setting them up for potential hypoglycemia and dehydration. And avoid changing from a PN, continuous PN to a 12-hour cycle in a 24-hour period or on the day of discharge. Again, setting the patient up for metabolic complications. You should reassess your GIR when cycling PN. Remember that you can go to a maximum of 7 milligrams per kilogram per minute. And remember that your maximal infusion rates for your lipid are 0.5 mils per kilo per hour or 0.11 grams per kilo per hour as well. So in terms of additives, we really want to try to minimize additives in these PN patients. It's a patient safety issue, a quality of life issue, and a reimbursement issue. Think about if you have 3 or more additives, the patient has to drop that solution into a vial, then inject it into the bag. There's a possibility, the more they have to do this, they could start to get tired, they may not have great dexterity, they could potentially puncture the bag, the more they have to do this. So think about safety, think about the quality of life, because it's stressful. The whole process is very stressful. And it could be a reimbursement issue. And then lastly, is the clinical need justified? So in terms of insulin management, we need, excuse me, water. We need to remember that we do not want to exceed 0.2 units of insulin per gram of dextrose in the PN formulations in order to cover the dextrose in the PN. You need to coordinate with your diabetic educator in an effort to have them come in and educate the patient about how to check their blood sugars, educate them about the signs and symptoms of hypo and hyperglycemia, as well as provide them with a glucometer. If they cannot provide them with a glucometer, you need to make your care coordinator aware that they will need to be sent home with an order for a glucometer and the appropriate supplies. And then lastly, shortages. That's been a terrible word for all of us in the past few years. We've all had shortage issues, supply issues. I think if I hear that supply chain word or phrase one more time, I'm going to go insane. Hospitals may have limited supplies of the PN component, and your infusion pharmacies may have greater allocations. So you need to communicate back and forth between the two entities to see who has what. And remember that if you've been only delivering lipid 3 times a week or multivitamins 3 times a week, try to incorporate a daily regimen, certainly of your vitamins, but also of the lipid if possible, especially if you've got someone with who has higher dextrose loads in their PN. It's better to have a little bit more balanced regimen, especially if you've got a diabetic involved. And also remember, we don't want to provide excessive amounts of dextrose or lipid, because ultimately these can caused some liver function abnormalities. I've included this just to be a quick reference and a quick reminder that we need to consider our macronutrients and electrolytes in terms of amounts per day. This is your after standardized PN order. Now, what I really want to focus on here is we've all heard, or many of us have heard, of CPOE, computerized prescriber order entry. And this is just an example of an electronic PN discharge order. And on the next page, you'll see the lipid order, because we're talking about a facility that has a 2-in-1 PN solution and a separate lipid set. And this, as you can see, includes the type of infusion, the type of central line, the volume, the access, and the amount of macronutrients and electrolytes in amounts per day. And it has a special instruction box on the bottom that says, this may be combined with 250 mils of phospholipid to make a 3-in-1 volume of 2,050 ml. Be sure you clarify the volume of both your solutions that you're using if you're in a facility that does 2-in-1 and separate lipids. So, the key points to remember: how many times you get that request, get the patient out of the hospital as soon as possible, okay? We're going to go through a case study about this in a moment. But in this particular case, always keep in mind that you want to send the patient home on a safe PN formula. Remember that the PN can be cycled, can be advanced to goal by the home infusion company. You may also want to consider that 18-hour cycle or 18-hour cycle prior to discharge, and avoid making aggressive changes to the PN prior to discharge. Okay, I would like to pass off to my colleague. We're going to have a handoff. Yay! Here, let me pass it. Okay. A clinical handoff here. And I'll be back in a moment. Okay. Let me. All right. Okay. You got a pocket? You got a pocket. Okay.
I will try to.
I'm going to do that. Is that okay?
You can hear. Well, yeah.
I'll be back. Well, we'll be both.
No.
Just use your. Okay.
Okay. I am ready. Okay. All right, guys. So now we're going to talk about, hello everybody, transitions of care for the patient on PN, the receiver. So the clinician at the home infusion pharmacy. And I have no applicable disclosures for this presentation other than employment by a home infusion provider. And all information presented does not reflect my employer. So based on the 2022 article by Adams and Bureau et al. Regarding safe care transitions for patients receiving PN, I just want to point out and emphasize using a standardized, systematic approach. Communicating effectively, cross-team collaboration is key. So communicating with your case managers, your doctors, your key players to help get this patient home. It's not just about, here's the PN order. There's so much that can go into this. And then understanding what potential risks we face with this high-profile medication, and optimizing safety along the continuum. And focus on a patient-centered approach. The patient is a part of this. They can't be left out. When you're going home on PN, the patient and their care partners play a critical role. So here I have a checklist pulled from this consensus statement from the 2022 Aspen publication. And it starts the day of admission, subsequent days, day of discharge, and then post-discharge. And when we, as the receiver, receive a PN, they're going to go home from the hospital to home. I look at really the first three critical things is, do we have reimbursement? Because we know PN is very expensive, right? And then, do we have an authorizing doctor? And I'll talk more about that. Do we have an appropriate central access? And do we have a nurse, or are they able to go to an infusion clinic? You know, all of these things are critical to making this work. It's not just, you know, the PN. And other things, the PN discharge order set. So how many of you work inpatient? What about home infusion? Okay, so how many inpatient or clinicians from the inpatient setting have a home discharge PN order? Yay! You make my life so much easier. So it's critical, and you can put monitoring parameters on there, and you know. But anyway, so having the PN discharge order, you know, electronically, and then the clinician handoff is a big part of this process. And it's really critical because, honestly, you guys have tons of medical records that you have access to. Home infusion providers may get, you know, half a page of lab or this or that. We're constantly trying to get information. And so the clinician handoff is really critical. Allergies. Do they have allergies to key components of the PN order? Soy, corn, egg. You know, so what do those look like, and what has been done? And is the patient an appropriate candidate to go home on this, you know, high-risk medication, which is PN? And do they have a care partner, like Marlene said? So this is kind of the receiver's view of all of this. So one thing I want to point out is we always need to secure a physician champion. And no, it cannot be a urologist or a hospitalist. You know, most appropriate doctors to partner with the home infusion clinicians and or the hospital nutrition support clinicians, you know, is the GI doctor, the surgeon, the surgical oncologist, the oncologist. But definitely, and oftentimes it's that doctor who placed the line. So they own the central line because no other doctor wants to touch a patient with a central line. Sometimes case managers might want to, you know, oh, the internist. Well, no, because the patient hasn't seen the internist in 8 months and it was for, you know, a worse, you know, so that's not going to fly. And legally, from a home infusion pharmacy standpoint, we have to have a physician. And this physician will be available for communication, transfer of clinical information, help manage adjunctive IV meds. A lot of times patients get home and they really still need their IV Zofran, or we need to add IV fluids before they end up in the hospital or with metabolic complications. And that's the last thing. Our goal is to keep them out of the hospital. So we need a partnership and a doctor that's really seeing these patients in follow-up in their office. And so it is a true partnership to make it successful. And then looking at standardized electronic PN orders, obviously we're in the 21st century. We need to, you know, we have to get everything electronic, standardized, and this is what Aspen recommends to minimize errors that are associated with verbal, handwritten, faxed orders, prevent errors with calculation, transcription, omission. And again, Aspen recognizes CPOE as the preferred method for communicating PN orders. So we all know that potential risks are always associated with PN, especially with the transcription of the order itself. And a lot of times this is contributed to, you know, transcription errors with legibility, readability, non-standardized PN orders, handwritten, incomplete, omission, shortages, substitution. And this is very profound, that an estimated 60% of medication errors occur during transition of care, meaning you're going inpatient on PN, now to home on PN. So 60%, And I think us as nutrition support clinicians play a huge role in preventing these errors. I just wanted to throw this in here, is the Aspen prescribing PN checklist. So you can see everything that should be considered into order writing for a safe PN. And then here's Marlene showed this too, the Aspen standardized PN format. So oftentimes, you know, as a home infusion pharmacy, we are told, oh, you have the order. Well, oh, I sent it, it's in the nutrition note. So that is not a legal PN order. If the order, description is in a nutrition note, or if it's part of the MAR, it has to be in an order set and complete, and, not where the NBI is on the MAR, the lipids are over here, somebody's writing lipidem here. Really, that's where errors stem from, and it needs to be dated and timed and have the clinician contact number on there. All of these things sound so minuscule, but it really helps expedite the process. So very critical, and so get with your, your pharmacies, your teams, and create best practices in your hospitals. Have a discharge PN order, have a discharge EN order. Can make a huge difference. So the clinician handoff. So once I have the PN order for transcription and compound for the home infusion pharmacy, I usually, always I make a point to, the clinician handoff is critical. So between the sender and the receiver, describing the goals of care, any specific metabolic or nutrition concerns, expectations for PN components. So a patient may be on a certain lipid and that clinician, they've been following the patient in the hospital and they don't want to substitute, and giving the clinical rationale, discussing potential shortages. So I had a patient, they're like, oh, we've got to get them home from the hospital and he's going today, and the first set of labs that come over, his CO2 is 12, and I'm like, okay. So I called the clinician. He's like, yeah, we have no acetate salts. I'm like, oh, none? None. So we had to collaborate and figure out a plan to safely get this patient home. And what we came up with, I asked, do you have any oral bicarb in the hospital? Yes, we do. And so put the patient on that. I said, well, I have acetate, so get the patient on that, get the level up to a decent level so we can safely send home without any complications, and then I have acetate. So that was covered. So it's just these conversations that can help expedite, because we certainly don't want to hold up discharge. And then documenting who you spoke to. I spoke to this clinician, and here's what we're doing. Here's the plan. Because the inpatient CPN order really looks much different than the home order. So clinical considerations for the home PN order. We're going to talk about some of these as we go along. So the catheter. So certainly, we need a central catheter. We have had maybe one or two go home with a midline, but we need a central catheter. And we need it to function. So, because we do have certain cases where the patients get home, the line will not flush, which sets them up for infectious complications, or, they don't have a blood return. So now we're sitting at home and we can't get the one set of blood we need for the whole week to determine if the PN formula is safe or not, or if it needs adjustment. So really need these catheters patent before. So befriend your ID team nurses, befriend the floor nurse. I know clinicians in general work miracles, but we have to keep working these miracles because because we may have to send the patient back to the hospital if the line is not properly functioning. And then if the patient has a port, maybe they can have it accessed before they go back home to resume their home PN because the nurse can't come out. So all of these idiosyncrasies, have to be in place. And then refeeding risk. So Aspen has the newest guidelines on refeeding, and our institution has actually implemented a refeeding risk section into our initial nutrition assessment. And that is because too, sometimes patients, maybe have just one bag of PN and they're slated for discharge. And they absolutely cannot stay in the hospital any more days, and so, identifying refeeding risk from the receiver standpoint, and if they're not at goal, you're writing the discharge order, it's okay, we can do that, I would rather them be, I call it practicing metabolic support, and then converting to nutrition support once we get them stable. So looking at their high-risk comorbidities, pre-feeding electrolyte levels, identifying when they've started in the hospital, and determining ongoing electrolyte and fluid, disturbances. And with this special, subset patient population, we're all concerned about them getting fed, but, you can do that with lipid and not get in, mitigate some of those electrolyte disturbances that you would see with dextrose. And the big thing with all the shortages, we're seeing some of these very high-risk patients aren't getting multivitamin every day. They're getting 3 times a week. Talk to your infusion company. Do you have MDI? Yes, we do. Add it daily. Do they need to continue thiamine? Yes, they do. Add it. So the next is fluid provision in the home PN. So the biggest thing, probably the biggest complication that we want to prevent from a home infusion standpoint is dehydration in the home. So the patients leave the hospital, and they don't have all of the ancillary fluids that they had in the hospital, and any patient with gastric decompression or high output ostomy fistulus, just put some PRN IV fluids on there, on the discharge order. They don't have to use them, but if they need them, they're there. And these are best practices too from some of the larger teaching hospitals, Emory, which really, optimize patient care. So our biggest is prevent dehydration in the home. I can't say enough. And as a nutrition support clinician, what the patient's fluid needs are. You don't have to, defer to the doctor. I mean, you can't, if they're acute, but what they need. So write it, put it on your order, add the fluids. It really helps to, in those first 2 weeks of trying to stabilize these patients in the home. And then metabolic complications. So, I think as a home infusion clinician, we have to identify these. Did they happen in the hospital? What's going on with their liver? Do they have an allergy to lipid? They haven't had lipids for 3 weeks. What's going on? Allergies. I think one of the biggest ones is the renal function, because we know that PN is renally, everything we put in there is pretty much renally excreted. So, oftentimes we'll have patients, they're ready for home, but their BUN is 55 and their creatinine is 1.8. It's far out from their baseline, but they gotta go. So our goal is just to not exacerbate that and hopefully improve that once we get them home and stabilize them. So electrolyte provisions, consider, the Aspen guidelines for electrolyte dosing. And if a patient is receiving 140 milliequivalents of potassium in their PN, ask why. Why are we giving that? Because that is, a super therapeutic amount, generally speaking. And we also look, when we do the clinician handoff, it's like, okay, have you been giving them potassium runs every day? And different facilities do it differently. So understanding how they derive this formula is important, and correcting acid-base disturbances before they leave, because we know it can affect their potassium and phosphorus. So knowing these metabolic disturbances that we can adjust the TPN for and prevent metabolic complications. And remember, and as far as the receiver, we get labs once a week. Inpatient clinicians, daily. You know, you can do a lot with daily labs. We are like, you know, and we have limited operations. I mean, we can't just recompound 2 or 3 times a week. So these patients really have to be pretty stable on their formulas, and the body is really miraculous at how it equilibrates and with these formulas. All right, additives. So additives, like Marlene said, it can be a quality of life issue. You know, identify the clinical need. If they don't need it, remove it. Do it, you know, give it a whirl if you can, because all of these things we're thinking about is for patient safety and quality of life. We also have stability issues. So in the home, you know, we do the 3-in-1 where the lipids are mixed in to the bag. And then reimbursement. But the biggest thing that has really driven up home PN ingredients is in 2019, the FDA unapproved drug initiative. So when these ethanol blocks, selenium, vitamin C were rebranded, and they're now under one provider, you know, one manufacturer, and so the costs have radically increased. And, you know, in home infusion, we can't itemize bill for those, so it's a lump sum. So just taking all of that into consideration, but if the clinical need is there, and that clinician handoff, you know, tell them that they have to have this. And then insulin, my favorite. And remember, if a patient does go home with insulin in their PN, home infusion pharmacies send out 100-unit vials. The patient's drawing it up themselves. So if they've never been a diabetic, you know, all I can say with insulin is practice conservatively if you're sending your patients home with it. And then if a patient has a cyclical PN, that requires, you know, in insulin, it requires glucose monitoring. So 2 to 3 hours into the cycle, you know, when you stop the cycle, and then maybe a time when they're off the cycle, so we can see where they are. And insulin is one of those high-risk medications as well. And they must have a glucometer. And then shortages. And like I think my worst day recently at work was when my pharmacist said we have no sodium chloride. What do you mean? What do you mean we don't have sodium chloride? Well, we don't. So that was a fun day. And so we all are very familiar, follow ASPEN guidelines regarding PN component shortages. Usually the home infusion pharmacies may have greater allocations than hospitals. And once these shortages are resolved, please revert back to your previous practices of daily dosing for multivitamins, lipids, you know, please revert back to that to prevent complications. All right, and then there's from the receiver standpoint, compatibility and stability is such a big, you know, has a lot of detail to it, and you wanted, you know, we're doing the 3-in-1 TNA, and consider the ASPEN standards, the final concentrations of your substrates. We also have built-in curves into our system. You know, it's pretty intensive. And then some pharmacies still have little chamber bags where you have, you know, there's more room for not being so rigid about the stability. So we're sending a 7-day supply of PN, so we have to have that compatibility and stability perfect. And that concludes what I want to talk about there. So Marlene, we're going to move into our case studies.
Go ahead. No, this one's fine.
Yeah.
Okay, as I mentioned earlier, we're going to talk about a rapid discharge scenario. Here we see a patient who was admitted to the hospital with a large abdominal mass with surgery planned in the next 10 days. So they really wanted to get this patient home as soon as possible. Like 10 days of nutrition support is really going to make a huge difference in the surgical outcomes, but remember, a little is better than none at all. So this patient came in as, well, this patient has got the anthropometrics listed. I've given you the estimated energy needs and protein needs. And on day one, they only had a peripheral IV access. So we initiated PPN, and you can see on the day one, the regimen there. We were probably a little bit more generous with the components we could provide there, but we did check the osmolality of the solution and made sure that it was less than 900 milliosmoles. On day two, since we had the central venous access in place, we changed the patient from PPN to CPN, increased the amino acids and dextrose, and the lipid remained the same. On day three, we were told, okay, we need to get the patient out today. Great. They've only had 2 days of parenteral nutrition and only day one of CPN, or 1 day of CPN. So we talked with our illustrious home care provider, who the two of us happened to work on this case together, and we discussed the best way we thought we could get the patient out safely. So we did an 18-hour cycle, left the protein the same, increased the dextrose just a little bit, and then provided more lipid in an effort to meet their nutritional needs, but also not cause as much variation in the glucose level. We were able to get this patient out at goal, and all the electrolytes were within normal, and they were successfully discharged on day 3. Okay, we're going to go to a tough PN discharge case study. Here. All right.
So we actually worked on this one together as well, and this one was a 52-year-old male with newly diagnosed stage 4 gastric cancer. So just the most horrific, case study or case.
It was awful.
And he had large volume ascites. He had pleuric strains, so they were unable to get a PEG or a G-tube in for decompression. So he actually, had to transition home with an NG. Not your average case, but it was more of a palliative type situation as well. He was on a his hospital PN was very high volume, of course. He needed the fluid because of all of his fluid loss. But it was a very tenuous fluid situation because he also had the ascites. And so collaboration with, between the sender and receiver and talking about this patient, we decided that we would just get him home on the continuous PN. He was okay with it, his wife. And then the next week, once the home PN labs looked, we just said, let's see what the home PN labs look like before we determine, before cycling. He was able to cycle to an 18-hour. Once we started cycling him, we did add adjunctive IV fluids for use when he was off his PN cycle. But we eventually got him down to a 14-hour cycle, and he had supplemental fluids to use during the day if he got, thirsty or had signs and symptoms of dehydration. And he actually, went home. They gave him 2 weeks, and he actually lived for 8 months, which at home with an NG, and he really had very few complications given this, horrific situation. But it was
quality.
Yeah, quality of life. But it was a safe discharge. We're not in a hurry. It was a safe discharge where he could transition home without disturbances, metabolic, fluid disturbances. And that's the goal. All right.
Now, I'm going to go back and we've talked about the processes, the transition processes, and the clinical considerations for the PN patient. Well, last but not least, that's no less important, are the enroll patients. So, now, as we talked about before, let me fix this. Okay. As we mentioned before, we have processes, we have the key processes and clinical considerations, and many of those you're going to see with the enroll are very similar to what we saw with the parenteral nutrition processes. So in an article, a JPEN article from 2017 on safe practices for enteral nutrition therapy, they put forth, again, key steps on for the enteral transition process. Certainly, as we've talked about continuously through this presentation, identification of the patient early on. We need to establish the enteral tolerance at the goal prior to discharge, because once these patients get home, they are not going to have all the clinical follow-up that they had while they were in the hospital. So it's really important to get them established well at their goals prior to discharge. You need to provide written and verbal instruction to the patient and the caregiver in advance of discharge, so they have a chance to review it prior to going home. And ensure that the patient and the caregiver can demonstrate competence in all aspects of the enteral therapy. Provide an assessment of the home environment, make sure that that is safe. Engage the nutrition clinicians with expertise in enteral therapy, just as we had expertise in parenteral therapy, we want to make sure we have expertise in enteral therapy. And before discharge, educate on how to obtain the necessary supplies and formula before they go home. Now, there. Okay, so just as we did for the parenteral patient, we also have a checklist for the enteral patients. Now, this was taken from two sources, an NCP article in 2016 and the Aspen Enteral Nutrition Handbook. And we have 4 basic topics. Again, I'm going to go through each of those. In terms of patient assessment, we want to make sure that the patient is clinically stable. They need to demonstrate tolerance of their formula prior to discharge. Now, if they're not at goal, we need to have a reasonable expectation that they're going to be able to tolerate the feeding once they get home. If not, we may need to convince the physician that we need to keep the patient a little bit longer. Because remember, the follow-up in the home is not going to be as frequent as the follow-up in the hospital. The patient and the caregiver must consent to the administration of EN at home. Now, that may sound a little silly, but oftentimes we've had patients get home and the caregiver says, "What? I thought a nurse was going to come out and do this for me every day." No, that's not the case. They may get a nurse if they have an enteral pump for their tube feeding administration, but other than that, they're not going to go out with any nursing care. Now, the assessment of the home environment is really pretty self-explanatory, so I'm just going to move on. To the caregiver education, extremely important. I think that we can't emphasize education enough. And this was taken from a couple of different, well, this is still part of those same 2 articles, but we need to determine the caregivers and set up a training schedule for that caregiver while they're still in the hospital. Get them engaged before you send them out. Then we need to provide education about the feeding device care and troubleshooting if there's problems. If the tube clogs, what can you do? If there's redness around the insertion site, what do you do? Explain the enteral delivery method, review the formula and the feeding schedule, educate them how to assess the enteral tolerance, and provide instruction on medication administration via the feeding tube. This is where we need to bring the pharmacist in to help with this whole situation. We need to determine the most appropriate type or most appropriate form of medication to be delivered via that feeding tube, and make sure that the feeding tube is not going to become clogged when the patient goes home. Care coordination, again, this involves all members of the multidisciplinary team. We need to identify the authorizing physician, and big thing, communicate the enteral feeding regimen to the home care team or HCT, and for all purposes, I'm going to refer to the home enteral provider as the home care team. It could be a little bit different terminology, but I'm just going to use that as a blanket explanation. And coordinate with a home health agency if the patient is in need of nursing. Now, as I mentioned before, a nursing visit will only be provided if the patient is going home on a pump to administer their feeding. So, essential components of the enteral education. This was compiled from two different Aspen sources. The points that were listed in both articles were listed in red here, but they're all very important. I think it's extremely important from the onset, before the patient gets that device placed, like a G-tube or a PEG, that they understand what this is for and why they're getting it. Explain the reason for the enteral nutrition in terms of incorporating short-term and long-term goals. Provide training on the feeding tube care and access site care. Educate them about the formula, the method of administration, the schedule. Review the tube flushing, fluid requirement, and hydration assessment. One of the quickest things that will bring an enteral formula or enteral patient back into the hospital is dehydration. So adequate hydration is of the utmost importance. Educate, again, on medication administration. Make sure they go to the pharmacist to determine the best form of medication. Instruct on enteral pump operation and provide troubleshooting. Instruct on the monitoring and troubleshooting of complications, whether they be mechanical, GI, or metabolic. Review the emergency care plan and provide contact information. So clinical considerations from the sender standpoint, some of these we've heard a bit before: identifying the patient, providing appropriate education, written and from a demonstration perspective, no changes in acuity, and transition to a more standardized formula. Let's say they come out of ICU and a peptide formulation. As they get out to the floor, we want to think about putting them on a more standardized product, intact protein product, not a peptide product. Document the need for any specialized formulas like renal or diabetic. Okay, minimize the use of modulars or eliminate them altogether. Transition to the most appropriate enteral access. We're not going to send someone out with a dog hawk tube or, a nasoenteric feeding tube in their nose. The majority of the time, we're going to have them generally on a PEG, a G-tube, a GJ tube, or a J-tube. We want to transition from continuous to cyclic or bolus, and set up a specific administration schedule, i.e. no boluses during sleeping hours. This is really hard on the caregiver if they have to get up consistently at 2 o'clock in the morning every day to do that feeding. Think about, if you're going to do feedings 4 times a day, think about 8, 12, 4, and 8, something like that. Establish specific flushing guidelines. Remember, we want to prevent dehydration. Instruct on the medication administration, how to monitor tolerance, hydration, tube patency, provide the troubleshooting guidelines for GI symptoms, etc. Establish tolerance prior to discharge, and make sure you have the appropriate and accountable physician on board, and provide complete enteral orders. Again, like incomplete parenteral orders go home, incomplete enteral orders oftentimes go home as well. Here's an example of the Aspen recommended standardized order form. One key thing about this is they list the enteral access device, the method of administration, the specific schedule, and I'm talking get specific, don't say 4 times a day, that's really important. And Those are some of, and flushing guidelines, flush, flush, flush. Here's an example of an electronic discharge order form for enteral feedings. Again, noting the type of the tube, the route, or the type of the formula, the route of the feeding, the administration method, and the flushes. Okay, considerations, clinical considerations for the receiver. The home care team provides the formula and supplies a home health nurses only if the patient is going with a pump. The home care team provides enteral with contact information and frequently supplies them with educational links to either their own in-house site or sometimes even like YouTube for videos. The delivery service personnel often conducts the home environment assessment. The home care team, non-clinician, calls the patient within the first 1 to 2 days to obtain supply needs and check on the patient's general status. And the patient is instructed to call the RD for more clinical concerns about their feedings. And generally, the RD will conduct an assessment within the first 1 to 4 weeks, reviewing the tolerance, administration, etc. Review beforehand what the patient and caregiver expectations are before they get into the home, because there's numerous misconceptions that take place. Lastly, our case study. Okay, we had a head and neck cancer patient. Okay. Oh. Okay, we have a head and neck cancer patient who came in on a home regimen of Nutrien 1.5, 4 containers daily, unknown home care company, unknown prescriber. He was not a normal patient at this hospital. He had a 40-pound weight loss in 3 months. Not good. Okay, not good there. So we've given you the anthropometrics, the estimated energy and protein needs, as well as the fluid needs. So the previous home regimen was the Nutrien 1.5, 250 mils 4 times a day. Okay, there we go. And again, we didn't know, well, we assumed that it was bolus feedings, but how often the patient was really doing that, we really don't know. For the inpatient regimen, we changed the patient to pivot 1.5 and advanced up to a goal of 55 mils an hour with pre-water flushes. Then for a home regimen, we recommended bolus feedings with a more concentrated formula and more of a normal standardized formula of 250 mils 4 times daily, but clarify the order in terms of specific times, 8, 12, 4, and 8, and provided flushes of water with 150 mils before and after each feeding, which should have been adequate, but maybe more or less, or maybe more, especially in the middle of the summer when it's 90 degrees. So I think we've hit both the parenteral and enteral transition of care. If you have any questions, we would be happy to entertain later on.
Yes, so we're a little behind schedule, so we're going to save the questions